medical content. Our website is www.clarity.com, where we have lots of live sessions conducted by eminent speakers across the globe. We have MedWiki services, which is medical Wikipedia for doctors only, that also you can read in your leisure time. We will invite all the doctors to visit our website. So now, without any further delay, I would like to hand over the session to Dr. Kanhu Charan Patro, sir. Over to you, sir.
Good afternoon, all. Today, last time we discussed about the tips and tricks in target delineation of the glial tumors. Now, today we are going to discuss about the target delineation in brain tumors other than glioma. So, as we know, in the morning, So, before target delineation, we should analyze, we should browse, communicate to the surgeons, pathologists. We should then deliver, and we have to take extra care. So we have to analyze properly the imaging system, the pre-op findings, post-op findings, post-op MRI. Then we just go through the literature and go for the study. So as before I tell about going to the imaging, I will tell about the window width and the window level. In window width, we can change the window width and window level so that we can able to generate proper windowing for the contouring. So how to do? So go to your Monaco or Electa system, select the windowing, then drag your mouse in the horizontally, the width will change, and vertically the level will change, and diagonally if you change, both width and level will change. So if you see what is the window level, means there is a total, you can see the whole picture looks bright, but in the right side window width means the face looks more brighter. So before only doing the contouring on axial slice is not advisable. As you see, this picture depicts that the drawing is seen the axial view, how it looks like. So always you have to take the axial CT, axial scan, coronal scan, and sagittal scan, and contour accordingly. So low grade glioma, high grade glioma, I have done, I did it in last session. Now we will discuss about the meningioma, medulloblastoma, whole brain artery, and pituitary. So in this thing, MRI protocol, we have to go for, when we are going for the planning, we should go for the usual sequence T1, T2 player, 3DFS fissure sequence for normal anatomy, 5:1 to matrix, 1 mm slice, no gap, no tilt, neutral neck. FOB should include nose, eye, skull. We need a DICOM CD for the transfer of the MRI to the planning system, and sequence as per your need. So planning CD usually 3 mm slice. We either give the contrast. If you are planning for SRS, we can go for the 1 mm slice, and from vertex to neck we have to plan it. So first we start target delineation in the meningioma. So meningioma, as you know, this looks a bright picture, and with some dural component, it is known as a dural tail, and some it is extra axial mass and compressing the brain. So if you want to go to the just summarizing your guidelines, histoacrop guideline for the target volume delineation of skull-based tumors, you can refer this article, and you can go for the skull-based tumors. So and you can go for the RTOG 0593 protocol for the meningiomas for the target delineation. So why it is so important? Because conflicts arises where is what is the GTV proper, where is the dural tail, where is the edema, where is the hyperostosis. So how to handle GTV, how to handle the dural tail, how to handle the edema, how to handle the hyperostosis. If you go to the target delineation by histoacrop guideline, WHO grade 1, usually you contour according to the MRI and rotator PET. There is a GTV, CTV expansion is not necessary, and you can plan for the 1 to 3 mm PTV, and you can go for the single fraction 15 gray or 5 fraction 25 gray SRS, or conventional fractionation you can go to 54 gray. But grade 2, grade 3, you have to give margins around 1 to 2 centimeter. You are around the GTV, and you can plan with a 2-phase treatment, and there is no concept of SRS in the grade 2 and grade 3 now, but we have to go for the conventional fractionation and around 54 to 60 gray in 30 fractions, and SRS if you are planning 14 to 16 gray may be an option for small recurrent tumors. So what is the concept? The concept is the dura, thickened dura, hyperostotic mass and enhancing hyperostotic bone and high enhancing mass. So this is these three things you have to keep in mind for the contouring the meningioma. So as you know, the dural tail is important for the us. So if you see, this is called dural reaction of the any meningioma. This dural tail is not necessarily you include all all dural tail. It is not recommended. Only the nodularity and thickened dura you have to include in your GTB. Don't include all duras. So dural tail GTB should not be modified with respect to the dural tail. However, nodular dural enhancement will be considered as a target and will be included within the GTB. Hyperostosis, there is a bony reactions in the meningioma site, skull bone reactions. So what you have to do? You have to see in the bony window. If there is a bone window, it is there. If there is some skull reactions, you have to include that bony hyperostosis area in your GTB. Whether I should include the edema or not. Usually, meningioma growth is due to ischemia and a BHG, not like a glioma, where it is a secretions of vascular endothelial growth factor, that is angiogenic factor spillover, that causes edema. It is not the tumor edema. It is not recommended to include the edema even in grade 2 and grade 3 tumors. And mostly it is mostly increased due to the vascular permeability and angiogenic factor buildup. If you go to the RTOG 0539 protocol, we have a group 2, group 1, group 2, group 3. In group 1, we have to put observation, like which are the group 1, it is low risk, that is in grade 1, gross total resection, subtotal resection. Group 2 is the recurrent grade 1 and new WHO grade 2 and grade 3 with gross total grade 2 only, and group 3 is the any grade 3 and recurrent grade 2. So grade 3 should receive 60 gray, group 2 receives should be 50 gray, and group 1 should go for an observation. These are the RTOG 0539 practical table. We can go ahead. So GTB, what should be the GTB and what should be the CTB? As I told, the concept of thickened dura, enhancing component and hyperostotic bone is your GTB. Give CTB 2 centimeter margin for the phase 1 in grade 3, and 1 centimeter is the to the grade 1 phase 2, and you can use 3 to 5 mm for the PTB according to your hospital protocol. So this is the very clumsy, you can see skull base lesions. So what should we do? So let's see one example here. So this is the lesion of left frontal region at the parafalcine region, where you can see this meningioma is there. After surgery, it looks like there is no a good surgery, but you can see the thickened dura here. Here, this is the thickened dura. So in these things, you have to define. It is known as a residual GTB. You have to contour the residual GTB. You can see after residual GTB contouration, you give 2 centimeter margin. After giving 2 centimeter margin, and for the CTB 54 and CTB 60, you give 1 centimeter margin. So this is the, and then PTB margin you give there. And handling the dural tail, as I told, your elongated dura along the skull we should not include. Only thickened dura or thickened dura as well as nodularity dura we should include. If there is a hyperostotic bone around this structure, this hyperostotic bone should be included in your GTB, and that should be better seen in the bone window. And never forget these things to see in the bone window for the hyperostotic area in the lesion. So the only giving the CTB is not sufficient. You have to trim your things from the skull, flux, ventricle, optic apparatus, and brainstem tentorium. So when you are suppose this green line is your CTB. If you are trimming away from the brainstem as a skull, always trim in the bone window, not in the brain window. So extra tissue you can find here. When comparing to the bone window to brain window, you can see these are high chance of missing. So never trim the your CTB in the brain window. Always trim in the bone window. If your lesion is confined to the plaques and attaching to the dura, you can you should include in go beyond the plaques around 5 mm opposite to the brain. If there is a lesion is around the ventricle, you should include the 0.5 mm, include the ventricular area. You don't abruptly cut the CTV from the ventricle by 0 mm, at least include the 0.5 mm inside the ventricle. Sometimes n-plaque meningiomas happen from starting from the skull area, it goes to the temporal fossa, it goes to the sphenoid sinus, maxillary sinus. You can see this is a plaque-like meningioma. It grow how it looks like, and sometimes this plaque-like meningioma you can see here, and see this n-plaque meningiomas. So you have to be very careful for these things, and you can see whole n-plaque meningioma seen now involving the whole part of the dura. So in these situations where you are not able to differentiate from the skull base to the tumor from the pituitary, you should continue as a gallium DOTA PET will helpful, and always take the advantage of the CT, MRI and DOTA PET fusion that will help you to the proper target delineation. There are many articles are there and evidence based, no need of going whether DOTA PET to be done or not. Mostly when you are going for the skull based lesions, the DOTA PET will be more helpful to differentiating from the normal bone to the involved one. So you can see there are the lesion is around going to the ethmoidal sinus, and this is the pituitary. This is the normal pituitary that will DOTA scan also will take. So this is the olfactory meningioma, small in the left dorsal bone. A normal pituitary also uptake. So big. So we have to find out properly. So DOTA PET will help mostly in the skull base meningiomas. How DOTA PET here, the MRI, CT, and this picture shows how it helps to differentiate between the other involvement and not. This will help you DOTA in the skull base tumor, mostly DOTA PET and MRI, CT. If you fuse combinedly, that will be more helpful. Additional margin unless is for benign meningiomas, grade 1 meningiomas, unless the CTB expansion is not needed. But if you are planning for the grade 2, grade 3 meningiomas, you have to include extra 1 to 2 centimeter margin around the tumor bed. So in a nutshell, target delineation of meningioma, the GTB should be defined by the cavity and enhanced component, residual nodular enhancement. Neither cerebral edema, normal dural tail should be taken into the account. Nodular dural enhancement or should be taken into the account. Grade 2, grade 3 meningiomas, you can plan phase 1, phase 2 manner. So if for the phase 1 manner, you go to 2 centimeter, and phase 2 go further 1 centimeter. And usually grade 2 CTB 54 grades is sufficient. Grade 3 is 60 grades required. PTB, you trim your CTB ventricles, plaques, tentorium, you can go 0.5 centimeter to the other side, and hyperostotic bone or indirectly invaded bone should be included in the GTB. And for the PTB, you can give 3 to 5 mm margin. Reducing the margins to modify organ site near is not generally permissible. This is all about things I told about the meningioma. Now I will tell you about the target delineation in the medulloblastoma. Medulloblastoma, as you know, it is a mostly pediatric group tumors, most malignant brain tumors in childhood, mostly either mostly posterior fossa tumors, and there are now many molecular groups are there. I'm not going to the details to the molecular groups, but I will go to the contouring guidelines only. If you see the CTB picture, the posterior fossa medulloblastoma, it looks hyperdense. Then CT, if there is some cystic and hemorrhagic components may be there. Contrast, there may be in enhancement of the solid component with the cystic component surrounded by. T1 contrast, you can see some patchy enhancements and patchy enhancement, and some cystic solid component again MRE it enhances with some cystic component. T2, you can see the minimal edema you will find out, and T2 abnormality also you can able to see. T2 flare slight edema you can see along the tumor, mostly not much. Then diffusion restriction, because it is a high grade tumor, you will find there is a lots of diffusion restrictions will be there in the solid component. And so you can see that there is a medulloblastoma, it looks bright on the diffusion weighted restriction images and not in the correspondingly in the ADC map. So perfusion scan, you can have a possibly go for a perfusion scan because of the high grade in nature, and new angiogenesis you will get that area may be the hyperperfused. So target volume, what should be our target volume in the medulloblastoma? In medulloblastoma, craniospinal irradiation, we have to include the whole brain, cribriform plate, skull base, cranial nerves, and foraminus. Spine, entire subarachnoid space to encompass the extensions along the nerve root laterally. Boost, posterior fossa boost or tumor boost according to your comfortability. CSF space, entire CSF spread, CSF space has to be treated to prevent the arachnoid distribution. Whether you do supine CSI or prone CSI, both treatment policy, the contouring policy is the same. Guidelines, you can go for the ISNO guideline and some SIOP guidelines and some arrow presentations. So what should I what should be the imaging protocol for this? So from the vertex to mid thigh, we have to do CT, MRI spine, T2, MRI sign, MRI brain, fiesta sequence, or for the fiesta sequence to understand the CSF spread and CSF areas, and FSPGR sequence for the FSPGR sequence for the normal nerve roots, and we can go for the 1 to 3 mm slice. So this is the SIOP guideline and COG guideline comparisons. There is some difference and some similarity between these two guidelines. You can go to these guidelines and see. I will tell you one by one. So the areas where you are able to, is a common practice. Your areas where you are able to miss and a high chance of missing, you can go to then do the contouring. So this is the contouring of the ethmoidal plate, cribriform plate. So contour this cribriform plate, and you can it visible better in the 3002 by 400 window width and level. Why this is important? Because olfactory lobe is here and some CSF spaces will be finding. So this contour this area. Then contour the lower part of the temporal lobe. This is again and some area we are able to, we are high chance to miss. Then contour the foramen ovale, foramen spinosum, foramen lacerum. So these cranial nerves or exits you have to do and you have to contour. So so how you can see this the fiesta sequence, how it is gives rise to see the 7th space, 8th space CSF areas. So you can if you have a fiesta sequence, or you can go with the CISS sequence. Fiesta sequence is a special sequence with a GE sequence, geomachine, and CISS sequence in the Siemens. So you can go for this control so that you can see the proper CSF spaces. And the second thing is mostly you have to control the all foraminas, and this foramina chart is given in the SIOP guideline from the cribriform plate, optic canal, supraorbital fissure, foramen rotundum, foramen ovale, internal auditory meatus, jugular foramen, hypoglossal canal. These are the cranial nerves. What are the exit from these foraminas, and these are the anatomical restrictions where you will find the foramina. So when you are going for the understanding the foramina, you should go for the 1 mm slice, total skull base, and you can select a bone window or auto skin window. You can able to see the all cranial nerves. Mostly confusion arises from the whether I will include the whole of the optic nerve or not. whole of the optic nerve or not. The CSF tracks around the optic nerve and reaching to the back surface of the globe. So majority of the expert pediatric radiation oncologists are including the whole optic nerve in the CTV. CSF in Meckel's-Cave, you can go for the CSF in the Meckel's-Cave, here the fifth nerve area is there, so you have to include that area also. CSF spaces in the seventh and eighth nerve, internal acoustic meatus, and that area should be included. You can see the CSF spaces, that is very important. Then people think that we should spare cochlea or not. In the CSI, you should not spare the cochlea, but when you are planning for the boost, we can spare the cochlea. So never try to spare the cochlea when you are in the CSI planning. Apart from that, foramen jugulare, that 9th and 10th nerve, hypoglossal foramen for the 12th nerve. So you have to see all foramina, you have to contour and give 1 centimeter margin. So as you know, these are the supraorbital fissure, foramen ovale, jugular foramen, hypoglossal canal, internal auditory meatus, and foramen rotundum. You have to contour all these foramina in your with if you are able to find out, it is okay. If you are not able to find out, with your help of your radiologist, you can contour these all things. The chance of missing will be less. So this is the thing how it contours, like you can see this all contours, the foramina contours are how this is like that. Then you give the margin. Shall I include the pituitary fossa in the tumors of CSI? Sorry, planning CSI? Yes, you have to include the pituitary fossa in the CSI, but not in the boost planning. So don't think that I will not include CSI boost or nothing. So you have to include the pituitary in CSI, but in the boost planning you should not include. So spinal CTV, it is very important. The nerve roots along the intravertebral foramen, you have to contour the intervertebral foramens. You should not contour only spinal cord or spinal canal. You have to, even in bone window, you have to select this area. You will see the all foraminas, intervertebral foraminas along the so ventral and dorsal nerve roots. You have to elongate the spinal canal along the lateral wall. Sacral canal should be included or not? Sacral canal, sacral nerve. So in CSF around the sacral nerves are in the sacral nerves did not show any CSF fluids, so sacral canal not need to be included. So previously we used to give the spared field, wider field in the older days, but SIPA guidelines says no need to give take the sacral canal, but spinal canal has to be included, not sacral canal. So how to understand where the spinal cord ends? So you can see here the you can see the thecal stake ends in the S2 lower level. You can see, so for this reason you have to take a sagittal picture with a T2, so that you can able to find out the lower level of spinal cord as well as the lower level of subarachnoid space. So usually according to the age, the lower level of thecal stake varies. Yes, in the 1 to 10 years of age, middle of S2, 11 to 20 upper border of S2, 21 to 30 it is upper border of S2, 31 to 40 S1 and S2. So it should be properly identified. If you are not able to find out, take the help of the radiologist. As I know, spinal CTV must be imaging of the lower end of the thecals on the spinal lamella. Infrared field should be at 1 centimeter. You give spinal field how much? 1 centimeter below you have to take. So as you know, the vertebral body, this is the intervertebral foramen. So this area you have to include. This area you have to include. So this area you have to include. If you don't include this area, your contouring will be wrong. Contouring is wrong. So you have to include this area. So this is the. So this is the intervertebral foramen spaces you have to include. It will be best visible in the bone windows. So this is the nerve roots. What I told before, this is the nerve roots. We have to include this area. The PTV margin should be usually brain. We give 5 mm margin. For the spine, we are giving 7 mm to 1 centimeter margin. Posterior fossa boost is again important marker. Either another step, you have to find out whether you should go for the whole posterior fossa boost or all posterior fossa boost and or tumor bed boost. Remember, no need to include the pituitary and cochlea in the posterior fossa boost. So if you have a doubt, so this is the evaluation of the posterior fossa boost from the bilateral field to the conformal field. You can see here. And remember, if you are planning for the tumor bed boost only, you fuse the old MRI, give 1 to 1.5 centimeter margin and plan accordingly. And only posterior fossa boost, the will be used just the external. It is the it is the posterior anterior posterior clinical is the anterior border. 1 centimeter above is the tentorium salivary upper border. Posterior is the skull. Lower is the inferior is the C2 C3 interspace. So this has to be included. So and so suppose you can find out the tentorium cerebelli in your MRI. If you are not able to find, you have to superior border. It is a 2/3 distance from the foramen magnum to the skull, and 1/3 2/3 distance from the foramen magnum to the skull. So some so what you do? You draw a line from the skull to foramen magnum. To at a 2/3 centimeter, a 2/3 junction, you can put your upper border of the posterior fossa. In conclusion, delineate the crevium plate properly. Give CT 5 mm below this. Delineate skull base foramina at least 1 centimeter below the skull. Delineate gular sheath of the cranial lobe. Give 1 centimeter. Delineate the inferior part of the temporal lobe. Delineate the PTB. Posterior fossa should extend anteriorly to posterior clinoid process. Pituitary is not included in the posterior fossa boost. Spinal CTB should extend to cover the intervertebral foramina. Inferior part of spinal CT must be must be seen below the by sagittal section of MRI, and this will extend to the inferior border of the second or S2 S3 interspace. So thank you. So so today I concluded the meningioma target delineation and medulloblastoma target delineation. Next time we will plan for the whole ventricular radiation, pituitary contouring guidelines, whole ventricular contouring guidelines, brain met guidelines, brain met cavity SRS guidelines in the next class. Thank you for the opportunity, and if somebody has a doubt, you can ask or put in the chat box. Thank you very much. Anybody who is in doubts, they can ask or directly, or we can put the questions in the chat box. Some doctor has asked grade 1 meningioma subtotal lesion, shall we should give RT? See, if subtotal resection, even it is coming the RTOG 0539 protocol, you can see this. You can see WHO grade 1 GTR or STR, it is a low risk of recurrence. But if there is a gross subtotal resection nearby the optic chiasm, nearby the vital organs, better to treat. Now, if there is another other sites, when there is no vital organs, vital structures are there, you can observe even in grade 1 GTR, GTR or STR. So if you have no questions, we will conclude the session. Over to clarinet.
Hello.
Yes, madam.
Sir, am I audible now?